So I'm delighted to introduce Ruth Benson, who is one of our vascular academic clinical lecturers at the University of Birmingham. She's also a senior registrar coming to the end of her training, we think, but she keeps stretching it out. She, in particular, was a member and recent past president of the Vascular and Endovascular Research Network, which is a research network which engages units across the country in collaborative research, and it's done fantastic work under her leadership. So she's going to talk to us about global vascular guidelines. Thank you, Ruth.
Thank you very much for having me, and good morning, everybody. I'm Ruth, and I've been asked to talk through some global vascular guidelines. When I first got the topic for this talk, which was, we were saying, well over a year ago, I initially focused on diabetic foot guidelines because there'd been a recent release. And then yesterday, I realised that the rest of my speakers were focusing on critical limb-threatening ischemia, the guidelines for which were also released in 2019. So I had a panic, and you've got a bit of a combination of the two, which I hope will be slightly more interesting. And although we've got to try and accommodate some of Chris Twine's talk next, I'll try not to solidly talk through half an hour of guidelines. These are the rough aims. I'm going to go through some of the background, the International Working Group for Diabetic Foot Guidelines, as well as our own global vascular guidelines, which were put together and updated in 2019 from the American societies, the European societies, and guidance reflecting the impact of COVID-19, which has actually been a bit more challenging than I imagined. The background to it is that for those patients with peripheral arterial disease in high, low and middle income countries, diabetes continues to remain a contributing factor. It's much higher in higher income countries, but our lower and middle income, for that title, means our colleagues and our patients in those are catching up very rapidly. So we know that the crossover between the two is significant, the relationship is unentanglable, and the patients that we are treating in the future will move from being male of advanced age and heavy smokers with familial hypercholesterolemia and moving all the way back towards diabetes as the broad and the biggest cohort that we're going to be treating. The difference perhaps in these patients is that it's multiple healthcare specialists who are looking after their care, which is reflected in the MDT who are at the meeting over these past few days. And the global and regional variability in practice patterns are really high, and that's not just because of guidelines, but actually because of disparities in access to care, education, and availability of the resources and the teams that we know we need to have to treat patients like this really well and focus on limb salvage, but also medium and long-term cardiovascular morbidity. So we know that there is a big disparity in the use of various treatments and clinical outcomes. These guidelines will be focusing on the global guidelines and what we would like to see care as, but accepting that that will change. So these were the 2019 updates in the Journal of Vascular Surgery, a huge global effort, a large list of names on the right reflecting a huge wealth of knowledge and experience, especially in the world of vascular surgery. And these are the practical guidelines for the prevention and management of diabetic disease from the IWGDF, again, who released an update in 2019. As you can see, a huge wealth, breadth of knowledge across all specialties. If you look closely, there might be some familiar faces, and some people managed to get their names on both. Importantly, they're all freely accessible. The guidelines are freely accessible online. The systematic reviews supporting them are freely accessible, as are the practical guidelines, which means that there is no barrier to accessing them and the information that they contain. So starting with the working group, there are 6 broad categories that they released in 2019. Categories 1 to 5, prevention, offloading, peripheral arterial disease, infection, and wound healing, were updates from the previous release. The classification guidelines, so classifying the type of ulcer so that it could be communicated between professionals, was newly developed in 2019. They also have those accessible sections for focused practical guidelines, and then also their development and their methodology. So they started focusing on prevention, and the guidelines have incorporated 5 key elements to underpin efforts to prevent the ulcers forming in first place. And the first of those is identifying the at-risk foot, and they've produced a very helpful stratification tool to use. Regularly inspecting and examining the at-risk foot an important part of that being patient and carer education so that they can take responsibility and have autonomy over their own inspection, which is hugely important, especially during COVID. Education for not just the patients, the carers and family, but also the healthcare professionals amongst them. And this is part of that, so that all of the professionals within the care understand different aspects of each other's care and there's no conflict. Also ensuring the routine wearing of appropriate footwear, and finally treating the risk factors for ulceration, which isn't just practical but also involves lifestyle, economics, and other cultural and inherent social beliefs. So this is the stratification for identifying the at-risk foot. And the main thing that they focus on is loss of protective sensation and a diagnosis of peripheral arterial disease. So in patients with very low risk, with no evidence of both, they give us a guidance for a once-a-year check, and that guidance increases as your risk increases. The one thing the guidance is very clear on before going to the at-risk foot is in the trouble with the low-risk foot is that often the loss of sensation or the arterial disease is subclinical. So we know that there are plenty of patients who have subclinical peripheral arterial disease because they're asymptomatic. And it means that they are still at risk of developing ulceration, even with good, palpable foot pulses. But it means that they don't act accordingly. And it also means that they're still at risk of the associated cardiovascular risk factors, which a lot of our diabetic patients are also at risk of. But in those at higher risk, we're talking about more comprehensive examinations, which include the following. And they've recommended an extra focus on end-stage renal disease, social isolation, and access to healthcare, including transport, financial constraints based on what they can and can't do, including employment and the inability, for example, to be non-weight bearing because they have to provide financially, and also pain, which we know from our chronic limb-threatening ischemia patients has a huge impact on their nutrition, on their fitness, and on contributing to very poor frailty. As you'd expect, a strong focus on skin, but also on bone, early bone and joint deformities, for example, claw or hammer toes. Focusing on the assessments for loss of sensation, their footwear, because if you're a low-risk patient, then you are, the guidelines suggest they can just buy footwear off the shelf, but as soon as you start moving into higher risk territories, you have to be more careful, and the guidelines do start recommending that everybody gets specifically designed footwear. Poor foot hygiene is an issue. We tend to see a lot of that in our vascular patients, especially those who come with neglected and very infected diabetic feet. And physical limitations that can hinder their self-foot care, like visual acuity problems, not having any help at home, and also obesity, which we know is now an ongoing and worsening issue. So when it comes to the global CLTI guidelines for that cohort, the crossover continues. So we know that we need to manage all modifiable risk factors, which for ourselves is managing with an antiplatelet to reduce their 5 and 10 risk, cardiovascular risk and associated mortality. Clopidogrel remains the agent of choice, and the 2019 guidelines have incorporated results from the COMPASS trial, which I'll talk about very briefly in a second, which means that the second line means we can, as surgeons, consider aspirin low dose, which for us is standard, 75 milligrams, and rivaroxaban 2.5 milligrams twice a day in patients with asymptomatic or previously diagnosed peripheral arterial disease, including carotid and limb disease, because we get reduced adverse cardiovascular events, specifically in this subgroup. Warfarin is no longer recommended. It used to be some recommendations, but now the excess risk of severe bleeding and potentially life-threatening bleeding are too high. Statin prevention is a mainstay of what we do, and we also know that it improves both short-term post-operative and peri-operative outcomes, including our graft patencies, but also our long-term cardiovascular mortality. And it also goes so far as convincing metformin is a primary agent for type 2 diabetes and limb-threatening ischemia. So very briefly, the COMPASS trial, from which we derived the guidelines about aspirin, and rivaroxaban, a 1.3% absolute reduced risk in cardiovascular death, stroke or non-fatal MI, with a 1.2 increased absolute risk in what they call major bleeding, but specifically non-fatal. So that's been deemed acceptable in the guidelines. Next has been educating patients, family and healthcare professionals And from this point of view, the guidelines are very clear that self-care knowledge and self-protective behaviour is absolutely paramount. And these patients must be given skills to facilitate adherence to this behaviour. They're not very specific on what those skills might be, but that gives everybody regional autonomy to educate patients in whatever way is deemed most suitable for your patient cohort. The patients to learn how to recognise ulcers, but also pre-ulcerative signs, be aware of the steps to take when problems arise, but also making sure that there's a very clear communication pathway for patients and their teams in the community so that they know exactly who to speak to when there are concerns. And then advice, very clear advice about self-care and hygiene, for example, cutting toenails. Footwear, most important with foot deformities and a history of a previous ulcer. Evaluating the patient at the end of the day is the recommendation because that accommodates swelling that's developed at the end of the day and on standing. We had a very interesting talk with an academic yesterday over dinner who has specialist interests in looking at pressure distribution, especially in these kinds of patients. So if available, it is recommended to use specialist equipment to confirm that the plantar pressure relieving effect of the chosen footwear is adequate for the patient's needs. This new introduction of a classification of foot ulcers to aid communication amongst professionals is to ensure that standardisation is there so that consistency is also there. The expected division between neuropathic, neuroischemic and ischemic, defining the cause of it so that you can identify the risk factors for the patient's future care, for example, ill-fitting shoes or a tendency to walk barefoot in the UK in winter, site and depth of the ulcer, diagnosing infection and recording it very clearly, and then also very specifically focusing on the holistic care and patient factors that may affect future healing and their ability to comply. A lot of us don't like that word very much, but to comply with the kind of measurements measures that we're asking them to put in place. The way the guidelines suggest identifying infection, that it should be classified using their own scheme. More details available in the guidelines. I've tried to resist putting lots of pictures, repetitive pictures in, but as you'd expect, mild, moderate and severe. Severe would be the one as vascular surgeons that we focus on because they're accompanied by systemic signs of sepsis, and we'd expect immediate review and transfer, and it should be accepted. You should have no barriers to referring these patients immediately to your local vascular centre for review on that day. Is there clinical infection? The guidelines, and this is education for me, would prefer us not to use swabs in those wounds, but actually to obtain a sample of tissue and send it across in a sterile container. The recommendations for diagnosing infection, and this is looking at radiology. Is it possible to visualise or touch the bone with the sterile metal probe? That has continued. Plain X-ray is the first line. We know that osteomyelitis is a very late diagnosis, so if osteomyelitis is still suspected, even if the X-ray is negative, then an MRI, and if not possible, then they have provided some alternatives. Tissue gas or presence of a foreign body is obviously cause for, again, urgent referral over to the vascular surgeon. Communicating with other healthcare professionals, they have included and recommend the SINBAD score. It gives you a score which incorporates the site, presence of ischemia, identification of neuropathy, evidence of bacterial infection, the size and the depth of the ulcer, and it gives a score which provides quite a helpful tool. The treatment is exactly as you expect, and I don't think there's been a huge amount of change from this point of view. Preventing repeated trauma, and that is being absolutely strict as possible on the offloading. Treating ischemia and infection, and then hospitalisation, depending on your local availability of services for the provision of any of the above. Especially if we have patients who are carers for others at home, it's impossible for them to offload. If we have patients who are working full-time, we know that it's impossible for them to offload. So sometimes there are accommodations that we would make if they didn't necessarily need to be admitted. COVID's provided us some challenges as well in terms of the availability of outpatient antibiotic provision, for example. But superficial infection, the idea remains to treat them as outpatients. Empirical therapy should be started. The guidelines continue to identify that Staph aureus and streptococci are the most common community-identified organisms. If it's deep infection, then again, vascular specialist evaluation. What they've put in here is if time. We know, especially in the UK, vascular services are very centralised. Internationally, the availability of vascular surgeons can vary in good time. So if a patient is very poorly and unwell, then it is quite reasonable to offer them emergency pus draining, emergency amputation, emergency debridement in that setting for life saving as well as salvage. Broad spectrum antibiotics covering gram-positive and negative, but also anaerobes, and that's for some of our gas-forming microorganisms as well, and then adjusting our microbiology based on results as soon as possible. Again, from our point of view, urgent revascularization if indicated, but as a rule, in a patient who comes to us with diabetic foot sepsis, even with confirmed peripheral arterial disease, the management of the sepsis is absolutely paramount, and then we'll move on to urgent revascularization, which comes into restoring tissue perfusion. The indications from the guidelines here are looking at an ABPI of less than 0.5. That's interesting for me. From a vascular perspective, we would not have such strict criteria for offering revascularization, and my senior colleagues might talk a little more about that in the next talks. Toe pressure is a very large part of what we do as well. Often we have patients with wounds that can't accommodate the ankle cuff, but also we know that with their calcified distal vessels, if they've got confirmed peripheral arterial disease, an ankle pressure will be falsely elevated. There is obviously room for clinical acuity, and even if you are unsure about revascularizing them because you don't think that their blood supply is compromised sufficiently to explain why they're not healing, if a wound continues to not heal after 6 weeks, this is a diabetic guidelines. In our vascular guidelines, we've got 4 weeks, so we've got slightly more, again, our threshold is slightly lower, then you would absolutely be within your rights, for example, to refer a patient to the vascular surgeon for consideration of assessment and revascularization. And also, if you look at a wound and you think that you're at high risk of major amputation, it is never unreasonable to fully explore revascularization options so that we can try and salvage a limb. From our surgical guidelines, this is our pathway for starting to stratify patients as to whether or not we would start looking at imaging to consider revascularization. As you can see, we start looking at our Doppler waveforms if they've got any sort of abnormal ABPI less than 0.9. So we immediately start down that route. And part of that might well be explained that the access that we have, for example, to non-invasive imaging, like duplex, is much quicker and much easier. And obviously, if there's any sign of tissue loss or gangrene, you're already in a tertiary centre. It is not a challenge for us to then go ahead and start getting imaging. So these surgical critical limb-threatening ischemia for the surgeon does reflect the fact that most of us will be in tertiary centres with much quicker availability. The Wi-Fi system remains key and is absolutely consistent across guidelines. It's looking at the extent of the wound, the ischemia of the wound based on those pressure measurements from an ankle pressure or from a toe pressure, and looking at the extent of foot infection. Wi-Fi or Wi-Fi, I actually meant to look it up before I came for the presentation. I think it depends where you are. But the essence of this score is that the team, it's a Texas team, validated this score to provide really strong evidence of the estimates for risk of patients' amputation, for major amputation at 1 year, and using it. And again, this is also freely available online. And it supports our decision-making as surgeons around our limb salvage efforts, and therefore how we counsel patients who've come in for an immediate vascular debridement of their infected wound ulcer as to how far we push, for example, attempting to revascularize their limb. Often that takes several months to recover. They might be on antibiotics for many months. They might be on antibiotics for many years. They might not be able to tolerate full weight bearing for up to a year. So there is often a situation where we might start talking to patients about early amputation. Alternatively, we might talk to our patients about early palliation, and that can take the form of simply managing their pain well, so permit them to have some sort of quality of life, spend time with their family, and there will be a cohort of patients for which that's very clear and obvious to us that we might talk to, patients who are bedbound, patients with a long history of dementia, for example, nursing home residents. That's just an assumption, because it is absolutely vital that any amputation that we do, unless it is an absolute life-saving event, is shared decision-making with the patient, with the carer, with the family, and also with our own multidisciplinary team, because a major limb amputation is not a small undertaking. It's one that we do a lot, but it is a hugely comorbid operation. Our guidelines ask us to estimate procedure risk and life expectancy. Now, as part of the Verne study recently, we ran a national study looking at all of our major lower limb amputations and asked our surgeons to estimate the risk of 30-day mortality, 1-year mortality, and we asked our anaesthetic colleagues to do the same. There are risk tools available, but as you may or may not be able to imagine, we were fairly blasé about the risks, and our anaesthetic colleagues, as a rule, identified a risk of 30-day and 1-year mortality almost twice of the one that we have documented routinely. And we are two people who are constantly being counselling our patients through these operations and potentially telling them quite different things. I don't know if that explains some of the psychology of surgery, and that if we truly understood or were very clear about the risks, we'd never do anything. My colleagues are laughing at the front. The reason it's particularly important in vascular surgery is because our guidelines define our average surgical risk, by which we mean the risk of our average surgical patient that we are putting through a major revascularization procedure, and we expect their peri-procedural mortality to be less than 5%. Now, as a rule, for a lot of our major vascular work now, we have spent a long time getting our elective mortality down to less than 1.5%, and some of our national vascular registries. For our critical limb ischemia, it is still an acceptable mortality at just under 5%. And we're allowed to operate on patients, or it's recommended that we do, if they have an estimated 2-year survival of greater than 50%. And what we take away from that, and what we already know, is that perhaps just under 50% of our patients, whatever we do, will still be dead at 2 years. We know for sure that at least 50% of the patients presenting with critical limb-threatening ischemia will be dead at 5 years because of the associated cardiovascular risk with these. So how do we decide on primary intervention and if we go on to salvage a wound or not? The guidance is quite clear. That it's all about, again, the risk estimate for those patients, but also about the local availability and your local expertise. And that takes into account, once again, the provision of the local health service, the patient's own circumstances. That comes a little more to the fore in countries with different health systems to that based in the UK, because economic and social constraints will often be strong indicators of how a patient is able to recover from major surgery. So primary amputation is more common in areas with delayed presentation, but also limited access to affordable post-operative healthcare and support. How do we make a decision on what level to amputate? This provides very helpful guidance. As a rule, we often decide between below knee, through knee, although the practice, especially around the UK, for through knee amputation is fairly variable, and most, or at least a proportion of surgeons will simply go for an above knee amputation. The healing rates for an above knee amputation are much better, but the ambulation after an above knee amputation is more than half that of patients who have a below knee amputation because of the biomechanics involved. But if you do have a below knee amputation, then your chance of then going on to have it revised to a through or an above knee because of blood supply or compromise because of infection or compromised tissue, risk factors like smoking, continuing to smoke, means that you might well be coming back to theatre for another operation. So moving off amputation and back onto revascularisation, offering all of our average risk patients is deemed to be reasonable, especially with advanced tissue loss. We can consider our high-risk patients, even if they've got moderate ischemia, if there's still been delayed healing to their wounds. And our best management, so we call it no improvement to their wounds despite best management, and for the vascular guidelines, as with the diabetic guidelines, that is infection control, good wound care, and good offloading. When it comes to imaging, we have a very helpful triage diagram. Duplex ultrasound, as a rule, is our first line because in most centres it is routinely available. There is no ionising radiation and there's no intravenous contrast. However, it is very user-specific and you have to have specialised teams, therefore it's not easily available in the community or in a non-vascular centre. When it comes to choosing between CT angiogram and MR angiogram, as surgeons, CT scans, again, much more easily available. But they're not very good at imaging calcified arteries below the knee, whereas an MR angiogram is very helpful when it comes to diagnosing calcified arteries and especially looking at the below knee vasculature. But ultimately the guidelines say that you do what is available in your centre so that there are no delays to imaging, and it's very pragmatic. Looking at adequate imaging of tibial and foot vessels, having foot views is absolutely vital to us because a lot of our diabetic patients will go on to need very distal bypass, and that means that you have to have a target artery for any imaging that you provide. A vein map, again, is absolutely paramount because the vein is our preferred conduit for a bypass. What's slightly newer in these guidelines is that we use a newer classification system for ourselves, and that's a classification system that we use to grade the complexity of the occlusion seen through the arteries. It's called the glass staging system, and it looks at your fem popliteal segment seen here, so above the knee but also below the knee disease, and you can get a score through. And the reason that's helpful is because you use the glass score to then be categorised into a stage, and they've managed to identify the patency rates for first-line endovascular management depending on how bad your arterial disease is. So you might be able to use that severity to then guide whether or not you offer them an endovascular first treatment or an open first treatment, again depending on the expertise within your centre. How much intervention? Often, I think, again, some of my bosses might testify, often it's a gut feeling. We make strong use of our multidisciplinary team meeting, especially in these higher risk patients, as to whether or not we, A, provide endovascular or open surgery first. If patients have got multi-level disease, if we immediately treat that multi-level disease in one sitting, or if we might delay the second stage of revascularization because they're high risk, because we don't have the availability of the kind of theatre we need to do both keyhole and open surgery in the same sitting. Certainly in my centre we still don't. But also whether or not you would then on table be able to image the vessels more clearly if you don't have good imaging to see if you do need to do something further. Because we will look at the foot peri-operatively and we'll see what the foot looks like. And if the foot does not look good after our first stage operation, that might be an indication that at the same sitting we then proceed to do something more complex, but to treat that second level of disease. Again, these are recommendations for us about the kind of treatment that we do. The one thing that you might imagine or take from this is that when we treat the artery that sits in the groin crease, we tend to prefer or have routinely preferred an open operation in the past. There is some work ongoing to start looking at some randomised data to compare endovascular treatments, because in our comorbid patients, using a keyhole and a balloon to open up the artery around the groin, which is very commonly affected in our patients, would be much lower risk, but we think the longevity is much less. In our high-risk cohorts, it might still be an option. But for us, surgery still remains the first line, and it dictates that we don't just treat the big artery at the top, but we focus very clearly on the branches that come off it, and that we use a patch to make sure that when we then close the artery, we don't narrow it at all. Endovascular first approaches. We thought we had some good research in the past to make sure that in patients that had moderate risk, open surgery was still first line. But I think it's fair to say that the trends across the UK continue to change. And if you have a centre with a very strong expertise and very good outcomes from endovascular management, then often that tends to be first line. But it's very good for those high-risk patients that we don't want to anaesthetise, who have an intermediate threat to limb, a significant and ongoing perfusion deficit, or those patients who don't have perhaps significant ischemia on the glass scale, but still have a wound that isn't progressing within 4 weeks. So we can start treating them a little sooner with our guidelines, despite again, our best care. Endovascular management can also be considered first line in patients who don't have a really good vein that we can use for a bypass, even though a bypass might perhaps be thought better. Endovascular first approaches, our guidelines say, for us, they are absolutely not suitable for complex, multi-level disease. And so for that, open surgery was recommended, even if our patients are high risk. Other things for us to consider, and for people to consider when we talk about it in the MDT and with our patients, we have fairly weak evidence for angiosome-targeted revascularization. I think we all imagine that it's ideal, and by that we mean focusing our revascularization attempts in the below-knee vessels that we think are most likely to supply the area affected by the ulcer or by the tissue loss. The evidence moves across, but the randomised evidence is not there. We're advised to do intraoperative completion imaging on table, especially our open bypasses using a duplex or an angiogram. Lumbar sympathectomy and prostanoids are no longer recommended for us. We sometimes use them in patients with intractable pain and poor reconstruction options. And we're asked not to offer vasoactive drugs to those patients if there are no revascularization options anymore, and for them to then move immediately to consider major amputation or palliation. Gene therapy is a really fascinating aspect of what we do. There are lots of very interesting centres and very interested colleagues who are starting to use gene therapy, especially with patients' own cells, to try and regenerate or improve regeneration and development of blood cells within critically ischemic limbs. And that might well be a really strong avenue in the future, but only as part of a trial at the moment. We have no evidence for our traditionally used medical therapies for trying to improve distal vasodilatation. For our follow-ups, the strongest evidence continues to be for smoking cessation. So if our patients continue to smoke, our revascularizations will fail. Dual antiplatelets are considered for prosthetic bypasses, for any of our endovascular treatments, and for anyone who's undergone repeated intervention. So if you see those patients and they're not on dual antiplatelets, please feel free to question us as to why, if it's a clinical decision or if it's an omission. Surveillance for all types of bypass for 2 years, and to actively treat them if we notice any significant stenoses or any concerning hemodynamic abnormalities. They also now recommend long-term follow-up for our endovascular interventions, which we didn't necessarily do, and I'm not sure we necessarily do now routinely. For our peri-operative amputation recommendations, and this is a bit of a bone of contention for us, if you're removing so ray is the level of the metatarsal for us, so removing the toe in its entirety and then a little more. That's what we imagine it to be. But if you're removing more than 2 of them at surgery, the recommendations now suggest that you actually immediately think about moving straight onto a transmetatarsal amputation at that sitting, and that you counsel patients for that, especially if the hallux is involved. Again, we were talking about that, about the regularity with which we see patients coming back with a little 5th toe still hanging on, with an ulcer over the 5th MTPJ, and these are those patients that we're talking about. We're considering revascularization even if we know a patient needs an amputation, but if we can get a patient from an above-knee amputation to a below-knee amputation, then revascularization is supported. Very early involvement of the rehabilitation team, which we know is absolutely vital. They don't just perform a practical role for our patients, but also an informal counselling role too, and then immediate offloading, especially if it's just digital or ray amputations. The organisation of care is paramount. How am I doing for time? We know that success, and hopefully you will all agree, is absolutely linked to a well-organised team, a very holistic approach, management of the ulcer, but as a consequence and associated with a multi-organ systemic disease, and good integration of the multidisciplinary team. So that would incorporate both in-house and perhaps community multidisciplinary team, ward rounds and meetings to discuss those patients that have been identified as being at risk. An ideal programme provision is described as having educational outputs for patients, carers, hospital and primary care teams, so that we all have an understanding of exactly what our colleagues do in hospital and within the community, and that we have shared goals, and we also give the right advice to our patients. Good systems in place to detect all of our at-risk patients, access to services to reduce the risk of ulcers, targeting chronic care to make sure and reduce the chance that patients will rock up to hospital with acute emergencies. And again, that means rapid access for treatment of any complications of the chronic ulceration, but also internal auditing, which is a strong recommendation and will always be. A small section on identifying the challenges of care in COVID-19, not a huge amount because this is quite a limited view and you all have your own experiences of it. A lot of our patients presented very late because they all had cardiovascular risk factors, so were self-isolating. The mood in patients, especially with chronic pain in our neuroischemic and ischemic ulcers, was already very low, and the self-isolation led to real drops in mood and severe self-neglect. There was a strong breakdown in care pathways, perhaps not as everybody caught up, but at the start of the pandemic, while everybody was just catching their breath and getting back on their feet. We had closure of our outpatient clinics, and so the easy resources that we had for early access for these patients was lost. And then reduced access to resources that we needed to support our major revascularization. We didn't have in-house hospital beds. We didn't have access to our post-operative high dependency units or our intensive care units, which we need for these high-risk patients. And that meant that we were suddenly unable to offer in a timely fashion the kind of urgent major revascularization that a lot of these patients needed. And I strongly suspect, and I think we already know from some data, that that would have led to potentially otherwise unnecessary limb loss if they had presented at another time, although at the time it would have obviously been a life-saving and limb-saving call. For focuses on outpatient care during COVID, focusing on outpatient communications for the initial assessment, diagnostic testing, including imaging, oral antibiotics prescribed remotely, use of home care services, although I'm not quite sure how that worked in the real world, and clinics away from tertiary care settings, so using our imagination and trying to provide clinics which prevented patients having to come into hospital in that that high-risk setting. Telemedicine has become huge, and it's certainly become huge for surgeons, even though we imagined a lot of our work had to be face-to-face and hands-on. There's been much more use of photos, using communication and messaging, accessible numbers for our patients and for their carers, and hotlines put in place for patients with foot problems so that they know exactly who to come to without having to be moved from pillar to post. There are obviously concerns about diagnosing a patient on a photo, and obviously everybody will have erred and probably still does on the side of caution, so perhaps we might see a few patients that we didn't necessarily need to, but that's never really a problem. The only trouble with telemedicine, perhaps, and this is slightly above my pay grade, but there are different methods of reimbursement by country for telemedicine compared to in-face, so there would have been complexities around the management of that and making cost cases. But we have to keep making it accessible. The good offloading will always remain a key part of this care for ourselves and everybody else as part of the MDT. And the main key factor was to make sure that we did no harm. So high risk or high skilled interventions and dressings that we frequently use in our diabetic patients, for example, negative pressure, we would just advise not to use. Again, we have randomized studies running at the moment to truly establish the benefit of negative pressure in this cohort. Surgical decision-making for us, we knew that even with COVID, there was a major benefit of intervention compared to the risk. As part of the vascular, endovascular global work that we performed during COVID, we looked at all of the interventions that were performed during the COVID itself, and very few of those patients actually were then diagnosed with COVID-19, less than 4%. The mortality, though, was still high because our patients presented late. The revascularization that we do, we had limited resources and again limited ITU beds for their care post-operatively. Absolutely. Our keyhole day case procedures were prioritised over bypass. That was a real change despite all of our guidance, and we had definitive amputations, far more of those prioritised over repeated vascularization. For those who have access, and you should have access to the presentation online, a list of resources for guidance during COVID-19. The conclusion, nothing new from what I've just spent a little while talking to you about. An advert for our definite study. Our trainees around the UK are going to start a study looking at intraoperative management for removing diabetic toes and diabetic foot debridement in the near future. So please keep an eye out. Thank you very much.